Thank you for joining me here today to talk about feeding difficulties in Eosinophilic Gastrointestinal Disorders, or EGIDs. My name's Carly and I'm a speech pathologist working in the area of infant and paediatric feeding. I practice through my private feeding clinic at Babble Munch Speech Pathology, at Offspring Child Health Specialists, and I have an appointment at the Royal Women's Hospital. In this talk, we'll journey through what feeding and swallowing difficulties are and some of the professional roles in feeding, including speech pathology. Then we'll get into looking at feeding and swallowing difficulties specific to EGIDs and look at some of the research in those areas, as well as thinking about how feed refusal and aversions develop in these children. We'll touch on some management principles briefly, and then some key messages for both professionals and parents to take away. And then finally, I'll share some of my favourite resources with you. And before I move on, I just want to flag that as many families have experienced, feeding problems can be extremely stressful and sometimes traumatic for families. So if anything that I talk about today raises concerns for you or your family, please do talk to your doctor or therapist. Let's look at what actual successful oral feeding requires. We need functional oral, sensory motor and swallowing skills. So our oral motor skills are the way we move things in our mouth, like our tongue and our jaw for chewing. And the sensory motor are the feelings, so the pathways that go up to the brain that tell us what we're feeling in our mouth. And then swallowing is the process of moving food from forward in your mouth, back and down, which we'll cover a little bit later. We need overall adequate health, particularly including gastrointestinal health. And this is so important in feeding and certainly working in a feeding clinic. I see so many kids with gastrointestinal discomfort and disorders, and that's as the focus of this talk, looking specifically at children with EGIDs. We also need central nervous system integration and musculoskeletal tone. So we need our muscles to all be working and supporting our body so that we can be upright and move for feeding as we need. And then we also need the environmental and the psychosocial supports around. And for children, this is a lot about their family and their parents. Let's move now into feeding and swallowing difficulties. Now looking at health and well-being and how it relates to feeding. We know that virtually any medical problem in a child can set the occasion for poor feeding. So underlying medical problems are a huge part of feeding problems. We also know that illness affects the motivation and the child's motivation to feed, affects their energy, their appetite, discomfort and pain, fatigue and stress. It also influences the child's emotional state, attitudes, openness to new experiences and ability to learn. So if a child's not feeling well or in a lot of discomfort or pain, then it's also going to be impacting the way that their emotional state, the way they're feeling, how open they are to new experiences. And as feeding is a sensory motor skill that develops in the first 2 years of life, any interruption to this process because of medical problems can then really impact feeding development. We also know that stress slows digestion, it delays gastric emptying, so the stomach can stay full for longer, it inhibits saliva production so the mouth can get drier, reduces appetite and your ability to respond to the feelings of hunger. So all those things play a role in feeding, they're important, and if you're feeling stressed, then you're not going to have that same appetite and drive to eat. Now, how common are childhood feeding problems? We know from research that 1 in 3 parents ask their child's doctor for feeding help. We also know that about 25 to 45% of typically developing children are reported to have some feeding problems at some stage. Now, typically developing in the studies is a bit of a broad term and maybe a bit of a misnomer as well at times. In some studies, it just means children that don't have a diagnosis of developmental delay or other like chronic medical conditions, but there might be other areas where their development's being impacted. But it does suggest that some level of feeding problems can be part of typical development. And we do know that some picky eating from say 18 months to 6 years of age is a normal stage of development. It's more about when it's really impacting their feeding or those family dynamics. Then if we look at studies of children with developmental disabilities and chronic or medical conditions, up to 80% of these children can have feeding problems. So we do know that feeding problems are very common in children with disabilities and children with chronic medical conditions. In the field, there are many terms for feeding difficulties and not one consistent diagnosis. So here's just a few terms that you might see or hear about or read in the literature. Some of them are not in use as much anymore. But if we were to look down and think, say, food refusal and oral aversion are used quite commonly. Oral aversion is used a lot in the medical professional area. It's not an official diagnosis. It's a term that's used and sometimes used synonymously with food refusal. And I will show you a little bit about the difference of that later on. Another term that you might see more commonly is behavioural feeding disorder. That's not a term that I like to use myself, because I feel it implies that the problem's with the child's behaviour. And again, we'll see later how that's sort of rarely the case. And then there are other terms that you might see. So there might be picky eating, which could mean sort of like a normal variant of picky eating, or it could mean like quite significant picky eating. So it's not necessarily a diagnosis. A number of other things, fussy, selective, or motor disorder. Dysphagia, I'll talk about that in a minute when we talk about swallowing, and then a few other terms there as well that you might see or read or hear. A couple of years ago, a group of feeding experts from around the world got together in an effort to come up with a consensus guideline and definition on what a feeding disorder is, so a diagnosis that we could use across the board. So this is that paper, and I recommend any professionals working with children with feeding difficulties get a hold of this paper, have a read of it, and keep it on hand. It can be classified into acute or chronic feeding problems. And the diagnosis and the emphasis added here is mine. A paediatric feeding disorder is the term that we're now using or attempting to use as a field. So it means impaired oral intake that is not age appropriate and is associated with medical, nutritional, feeding skill and or psychosocial dysfunction. So with that emphasis there, not age appropriate is that it's based on developmental norms, so comparing to what is the norm for the development. So associated with, so it's not in isolation, so not just typical picky eating, and caused by or linked to problems in medical, nutritional, feeding skill or psychosocial dysfunction. So it's a very broad thing, but it includes a lot of the children that we work with feeding problems, and it's a diagnosis that you'll hopefully see around more now instead of so many different broad terms. Now I'm just going to quickly touch on some different professional roles in feeding difficulties. So feeding really takes a team, and at the centre of that team we should always remember that it's the child and the family. So they're really crucial to this, looking from the child's point of view, child-centred, family-centred care. Then thinking about a team, we really do need a multidisciplinary group. So that will be different medical specialists, different therapists. So we've got the speech pathologist, the dietitian, OT, physio. We might have nursing, lactation, dentists, mental health clinicians, and other specialties. And in different countries, there are some different crossovers between some of those therapists. Like in some countries, occupational therapists do a lot more feeding. They do some feeding here in Australia as well. And, you know, some other professionals in different countries too. Most people don't realise that speech pathologists work with swallowing disorders and feeding problems. We're often thought as the communication people, but we are trained in the neurology, the anatomy, the physiology of swallowing, of all the muscles and nerves and systems involved. So we do play a central role in the assessment, diagnosis and treatment of infants and children with swallowing and feeding disorders. We conduct comprehensive feeding and swallowing assessments. We diagnose paediatric oral and pharyngeal swallowing disorders. So dysphagia means swallowing disorder. So in this picture here we have the mouth. Here's the tongue, here's the roof of the mouth, and here's a little blue piece of food I put there to stand out. So that is the oral area. Here we have the pharynx, the throat, and that's the esophagus, and then the airway here. So an oral stage problem is when a problem with eating in this area. A pharyngeal stage problem is a problem with the food or fluid moving through the throat. And then we have esophageal dysphagia. So that's where we have problems with the food or fluid moving down through the esophagus. So we're responsible for diagnosing oral and pharyngeal swallowing disorders as a speech pathologist. But in terms of esophageal dysphagia, we are responsible for identifying signs and symptoms, but we need the medical professionals such as the gastroenterologists to make the diagnosis and the management for those. We provide treatment for swallowing and feeding disorders. We refer patients, and a big part of our role is advocating for these families and children to get support they need. Now we've covered all the background, we'll look at feeding and swallowing difficulties specifically in children with eosinophilic gastrointestinal disorders. So that is often in the research children with eosinophilic esophagitis or EOE, but sometimes it's a broader group of children with EGIDs. So firstly, how common are feeding disorders in these groups? When we're looking at the association between feeding difficulties and children with EGIDs, we can look at it in two ways. So first, let's look at how many children with EGIDs actually have feeding difficulties. So looking at these few studies, there's a range of about 16.5% to nearly half of children with EGIDs also having a feeding difficulty. And there's a bit of a range because the studies vary in their methods, in their subgroups of what is considered a feeding difficulty and isn't, and sometimes the narrow definitions of a feeding difficulty. But the main takeaway is that feeding problems are relatively common in children with EGIDs. Now if we turn it around the other way, we can look at how many children who have feeding difficulties actually end up or have a diagnosis of an EGID. So in this study by Whitmer, they looked at over 1,400 children with EOE and compared them to about 2,800 cases, control cases, so children who had no EOE. So in that study, they looked at all the children who had earlier reported feeding difficulties in the first 6 months to see what the association was with an EOE diagnosis. What they found was that infants with early infant feeding difficulty in the first 6 months of life were at an increased odds of EOE diagnosis. So for those interested in the stats, the increased odds of EOE diagnosis was 1.45, which means that the odds of receiving EOE diagnosis when there were infant feeding difficulties was a 45% increase in odds compared to those who had no feeding difficulties. They also found that there are increased odds of EOE diagnosis associated with early cow's milk protein allergy, eczema, and reflux, among other areas. So the takeaway from this study that's relevant to us today is that a history of early infant feeding difficulties may help raise suspicion for EOE in children with other symptoms, including atopic conditions, and direct the need for further testing. Rivera, Neves and colleagues looked at a group of 93 children referred for severe feeding difficulties to the hospital clinic. So they had an intensive outpatient treatment program there, and they were referred due to not progressing with other feeding therapy. So all these children saw the gastroenterologist and the multidisciplinary team. I think not all had scopes though. And what they found is that 15% of these children with severe feeding difficulties actually were found to have a diagnosis of EOE. And the main takeaway from this study was that EOE is relatively common in children with severe feeding difficulties that have not responded to standard feeding therapy. Eddie Reddy looked at a group of children presenting to hospital with esophageal food impaction, where food becomes stuck in the esophagus. They excluded those who had foreign body impaction, so like if they'd swallowed a piece of Lego or a coin or something. Most of the children had scopes with esophageal biopsies. And they found that 74% of the children with biopsies who'd had biopsies were found to have EOE as the cause for their food impaction. So the main takeaway from the authors for this study was that EOE must be considered in all children presenting with esophageal food impaction. And so you think of esophageal food impaction as being an esophageal stage swallowing disorder. So it comes under that part of feeding difficulty, but it's part of the esophageal stage. This was a very interesting study by Heifert and colleagues. They looked at data on 45,000 children with autism spectrum disorder, or ASD, and compared them to 200,000 children without ASD. And then they looked more closely at those that had a feeding disorder diagnosis to compare the groups and see how many had an EOE diagnosis. They found that feeding disorders were the strongest predictor for EOE in this group of children, regardless of having ASD or not having ASD, when you compared it to all other variables studied. So that includes having an allergic or atopic condition, which were also associated with the diagnosis, just not as strongly as having a feeding disorder. So even though in this study children with ASD were more likely to be diagnosed with EOE compared to the controls, there was no difference in the odds of EOE diagnosis between those with ASD and not if you looked at those with feeding disorders. So having a feeding disorder was the important part in predicting an EOE diagnosis, not whether or not they had ASD. So the key takeaway point, the authors recommended that children with feeding disorders should undergo endoscopic evaluation to evaluate for EOE as a possible contributor to feeding difficulties. I do want to say on this study, just keep in mind they're likely looking at a very narrow group of feeding disorders, possibly more significant feeding disorders based on the way they found or pulled out that feeding disorder diagnosis in the study. Let's look at the types of feeding difficulties in children with EGIDs. So there's a few different things that we can see. We do see food refusal and aversions more commonly. We see frequent gagging and vomiting. Dysphagia, food impaction or discomfort on esophageal phase of swallowing is reported more commonly. So that can be the sensation of food getting stuck when they're swallowing. Decreased variety and volume of intake is reported, and that might also be part of restricting because of pain. Reduced appetite, delayed or immature oral motor skills, and if you think about these children having more periods of refusal potentially or a restricted diet, maybe because of their, what they need to exclude, sometimes needing to go to like elemental or liquid diets, and therefore limited opportunities to build those oral motor skills. So we tend to see more immature skills rather than disordered ones. We do see some slow chewing or avoidance of highly textured or firm foods, and that might be because more textured or firm foods might cause more pain on swallowing, delayed self-feeding skills, learn maladaptive feeding behaviours and behavioural feeding problems. So that's a bit about what we see them doing in the way that they refuse or are trying to escape that feeding situation. Chronic discomfort with meals. And then there can be a lot of problems around the disordered feeding relationship, because feeding happens in a relationship with your family, with your parent, and your siblings. So it can distort those relationships, it increases parental stress, and can lead to problematic feeding strategies to try and get food into children. And then some children do require some tube feeding. We can also look at age differences in EGID feeding difficulties. So it does tend to group a bit in some of the research, and it varies on what's considered younger or older, but in some studies younger is sort of 0 to 4, in others it's 0 to 7, and the older children is often like that sort of 7+ age. But in younger children there are more reports of failure to thrive, food refusal, just the broad category of feeding difficulties is reported, behavioural feeding problems as that label, and unexplained oral aversion. Whereas in older children, in the research, there's more reports of that esophageal dysphagia and food impactions, that food getting stuck, tends to happen more when children are older, not so much when they're younger. Now let's look at food refusal and feed aversions and just think about how they develop, because I think that's important to understand what's this link between pain and problems going on here with the swallowing or in the esophagus or other parts of your GI, gastrointestinal tract with an EGID, and this food refusal and aversion. How is that link made? So this is a quote I always go back to, and I always remember this: children refuse for a reason always, and I fully believe that. So as a speech pathologist, I see that if a child presents to my clinic with food refusal, it's my job to understand the child's own experience and to understand the root cause of that refusal. So sometimes this is clear, and sometimes you have to really dig deep into the history and the symptoms, and really just watching what the child is telling you through their body and their behaviours, what they're telling us about their own experience. So part of that assessment as a speech pathologist is really getting to the bottom of why is this child refusing, and that's really important to work out before you can then move forward. So let's look at how feeding aversions develop then. So we think of aversion, it's the child's learned protective response to what's going on in their environment around feeding. So this could be from their internal physiology, so the feelings happening inside like physical pain or other issues, what's happening in that feeding situation, and even interventions. So it could be medical interventions or sometimes even therapies, like things that make things feel worse for children. So we think of, as an example, if you've got gastrointestinal pain and discomfort and you're having that frequently, and then you pair that with repeated feeding experiences, because we eat multiple times a day, but you're pairing that with pain and discomfort through those repeated feeding experiences, then over time children learn that this is not a comfortable experience, and so they make that association, that link between eating and discomfort, and so then that can become a feed aversion. And what's really important to know here and to differentiate is that it's a continuum. So if we think about things being a protective response through to a full aversion and what might become more maladaptive behaviours. So a protective response, if we have pain or feel uncomfortable and unsafe when we're swallowing, then our immediate response, and that would be for us for an adult as well, is, oh, we want to stop that or we want to get away from that. So refusing food in that instance of feeling pain is a protective response. That's how they're trying to protect themselves. What happens though through learning is that then through repeated experiences, this can then become linked and become the aversion. So even if that pain or discomfort is removed or treated, that learning can still be there, that that feeding is not something that's great. It's not great for me, and I want to avoid that. So that's how it moves from protection, which can just be refusal, to a full aversion, where it's this learning and this anticipation and this association. So pain and nausea, when associated with eating, is probably one of the best predictors of subsequent food refusal. And I quote this because I see it all the time working with children with feeding problems. Pain, particularly gastrointestinal discomfort and that nausea, is so important in what's going on with feed refusal and feeding aversions. So it's something we really need to keep in mind and manage. So going back to that behavioural label, is it just behavioural? So if we looked at a couple of studies here, these are from big studies coming from more like medical clinics in hospitals. So Rommel and colleagues found that 5.4% of the children that they looked at had an isolated behavioural problem. So that was saying all the other 95% or so children had some other medical issue or other issue linked with their feeding problem. And then Field, also in 2003, found that only 2.6 of their group of children did not have a medical problem associated with feeding difficulty. So in these groups, it's quite rare to actually just have a feeding difficulty on its own, and that's going back to that children refuse for a reason. It is worth noting that that they're only looking at really obvious medical problems and diagnoses, so it's not considering other factors, developmental factors and things. So it's possible these percents are actually lower than this, I feel. Okay, now I just want to take you through something called the worry cycle. This is really helpful for parents and health professionals to understand. It was put together by Cardia Rowell, who's a doctor, a paediatrician in the US, and it's called the worry cycle, looking at the way that feeding problems progress. And so I'm just going to take you through this and look at this when we're thinking about children with EGIDs. So if we start with a feeding challenge, so in an EGID, we might have children who are refusing to eat due to pain or discomfort. That might not be a full aversion, it might just be a little bit of refusal, or it might be only eating certain textures or eating small amounts. So that's the feeding challenge that we might start with if we're going to start somewhere. And then if we think about the parents, we know that parent stress, there can be higher levels of parenting stress related to higher frequency of feeding problems in children with EGIDs. That's been studied and shown there by Wu and colleagues. And we also know that families get a lot of poor advice about feeding. One example will be he'll eat when he's hungry. We know that's not the case for children who have other problems that are preventing them from tuning into their appetite, like EGIDs. So these children won't eat when they're hungry if they've got significant feeding problems. So these kind of things, the worry, the lack of information support, and the poor advice can then exacerbate these feeding challenges. Parents can then move into counterproductive feeding practices in an effort to help their children to eat. So we do know from research that there's a higher frequency of problematic feeding strategies from parents of these children, and it's in an effort to support adequate nutrition in the child. So that might be things such as coaxing, pressuring, forcing, and bribing, and we know these things actually work against good feeding development. And I do want to add in here that this is, feeding is difficult. It's difficult for the children, it's difficult for the parents, and there's no blame in this exercise or this cycle. This is just the cycle of that feeding relationship that families find themselves in, and we see very commonly. So then if we move along, those counterproductive feeding practices lead to pressure, and that pressure then leads to resistance from the child. And we know from a lot of research, there's a lot of strong research around this, that children pressured to eat more food actually tend to eat less food. And we see that over and over again. And if you want to look into more around that area, Ellen Satter, so that last reference there, has a whole website, the Ellen Satter Institute, and something called the Division of Responsibility. And we need to take that into account considering all the feeding medical problems as well. But we do know that when we're pressuring as well on top of all those other challenges, that it can lead to more resistance. And so then it can go on as a cycle. More challenging behaviour, more worry, more pressure, more resistance, more pressure, and on and on. And so this is a really difficult and tricky cycle for children and families. It's something that's extremely stressful, and it sort of becomes quite prevalent of taking over mealtimes as well. And it's something there that I, as a speech pathologist and a therapist, this is also where we can help families. So now just let's look at some management principles in brief. So feeding difficulties, when we think about children with EGIDs and feeding difficulties, there can be some persistence of feeding problems because feeding difficulties are refusal and aversion are really complex. It's a combination of those biological, medical factors and learned factors and the environment. And all these things interact and overlay on top of each other. And even if you take one away, there might still be other layers there. So it is quite complicated. We know that in one study here, feeding dysfunction persisted in over half of children with EOE who had resolution of their esophageal inflammation on biopsy. So their esophagus had improved, the inflammation had resolved, but their feeding dysfunction persisted. And again, in another study, 27% of infants and toddlers with EOE did not have a reported increase of oral intake and weight gain after they had their initial EOE medical treatment, successful medical treatment. And we also know that these children may progress to more resistant feeding behaviours despite the EOE resolution. So it's important that we consider feeding as part of this treatment for children who are struggling with eating and swallowing problems, not just the medical side. EGIDs can derail the development of oral feeding and alter family mealtime dynamics. Despite effective medical treatment, the impact on feeding can persist and must be addressed. So the multidisciplinary approach is really important. We need to consider both medical and therapy. So the medical management is essential. We know that medical management of EOE and EGIDs is really important, and we've heard a number of talks this week around the medical management. But we also need to combine that with feeding therapy where required. So from the medical point of view, if we're not dealing with the underlying medical issue, particularly if it's continuing to cause pain, then we're going to really struggle to make progress in feeding therapy. But then on the other hand, if feeding problems are significant or entrenched, then no amount of medical management is going to shift that without addressing the dynamics of what is happening in feeding and that child and family experience. So we really need both working in partnership. We know 70% of children with EGIDs and feeding dysfunction required feeding therapy in this study here by Makata. So thinking about our treatment goal when we've got children with EGIDs and feeding problems, then we need to avoid further negative or painful experiences around feeding, and which medical management supports that, and change the child's expectation for pain. So it's going back to that aversion thing where they've made that learning and that link. You can then unlearn that and learn positive experiences and link them with feeding, but it takes time. So children with EGIDs often require consultation with an experienced paediatric feeding specialist. And here they've said once inflammation is treated and appropriate diet is identified. So yes, therapy is important once medical management has happened, but we also find that sometimes these kids' medical management can go on for a while, and there are things that we can do in therapy that can start early and work around building some positive experiences and building some family routines and methods for feeding that can support and build the foundation, so that then once we have more treatment of that inflammation and the dietary things as well, and then symptoms have resolved, then we have another foundation that we can build on top of that. So I don't think we need to wait until medical treatment's completed, and I'd recommend referring these kids early. So the first step in the treatment of an oral aversion is the diagnosis and treatment of any underlying medical causes that led to the orally aversive behaviours. So thinking about feeding therapy and what's our focus, as a speech pathologist, my overarching goals are always to support safe, efficient and pleasurable feeding experiences. So safe is really about the swallowing, because speech pathologists are responsible for seeing if a child can swallow properly or not, and if there's any aspiration, so any milk or food going the wrong way down into the airway. So that's the speech pathology role. So that's the safety. Efficient is about skill and how hard you work for that. So it's about, babies, they're sucking and swallowing and breathing, and they can take enough in that time. For children, it might be how well they chew. Are they learning the skills that they need to feed themselves? And pleasurable feeding must not be forgotten as well. So we don't just want to focus on the task, we want feeding to be enjoyable, so children grow up learning or enjoying how to eat. other areas that might be part of feeding therapy, and remembering that this is a multidisciplinary team, so part of adequate nutrition, weight gain and hydration, that's often working with the dietitians who are involved in that area. Developmentally appropriate feeding, so we're thinking about their oral motor skills, their oral sensory skills, we're thinking about their self-feeding skills. Can they sit up? And for children who might have other like low tone or gross motor delays, they might need the involvement of the physiotherapist or the occupational therapist, who can also help with like hand skills and self-feeding. So it takes a team for that area. And then also we want to think about the child as a person, as an individual. So we want to respect their communication and their autonomy, so their own personal agency. And we do that by helping to reduce pressure around mealtimes is one area. And then promoting that positive mealtime interaction between children and their families, which for some can be quite tricky to start with, because with that worry cycle we saw before, we've got quite far along. And so we need to backtrack and sort of re-engage at a different level. And then a big part of our role, as I mentioned before, is advocating for the child and the family. So even though I can't diagnose esophageal disorders as a speech pathologist, or allergies or reflux or other things, I can be looking for symptoms, signs and symptoms of those, asking really detailed questions in my case history. I spend a lot of time with families. So, I might be the first person to ask about some of these things. And there are children who we've seen who've come to us for feeding problems, who have then, through that process of feeding assessment and red flags being raised, have been referred and then diagnosed with an EOE diagnosis. There are many different models and therapeutic approaches to feeding therapy. So I just quickly wanted to show you what the model and approach that I use myself, which is responsive feeding therapy. So that's backed by a research base in responsive feeding that's gone back many years. And really it's the premise that interventions in early childhood should follow typical development as much as possible. So we're modelling things on what is the ideal, the typical development. And it's about facilitating discovery or rediscovery of internal cues. So we're thinking of that hunger and fullness and that drive to eat, because we're born with that drive to eat, and then sometimes pain, reflux, inflammation, allergies override those messages and they can get lost. So we want to discover or rediscover those internal cues, the curiosity, so the wanting and to eat, the being interested, because children in their development, part of developing and moving forward is that curiosity to learn. Using their strengths in that, and then while building their skills or mastery. So that's thinking about the oral motor skills and their ability to self-feed. So I think that's a nice little summary of what responsive feeding therapy focuses on. It takes place within trusting feeding relationships, so the relationship is central and that trust is central. So it's not only child-led or fully adult-led, but it's sort of a dance between the two, and the relationships between the parent and the child and the therapist, and also the parent and the therapist. And one of the main premises of this is that children can be trusted to gain or regain feeding skills within a supportive environment. So we're going from a strengths-based model that children want to eat, they want to learn to eat if everything was right in their world. And when they don't want to, that means that there are things going on that are preventing them and holding them back. So how can we set up that environment? And some of that's the medical environment and what's going on in their body to help support them regaining those feeding skills. So working with speech pathology, I'll just talk to that for a minute for those who aren't familiar about what specific problems we would work with or how to refer to us. So I would recommend referring to speech pathology if you're working with babies or have a baby who has poor sucking or swallowing at the breast or bottle. They might have long feeds, poor intake, breathing difficulties during feeding. Coughing, choking, gagging, or vomiting during feeds. So occasional gagging when they're first learning textures is normal, but ongoing gagging or gagging that's significant or causes vomiting or distress is not typical. Difficulties with chewing or swallowing solids, feeding refusal and aversions. They, require intervention. They require referral usually. And refusing certain textures or not transitioning to the next stages in solids. So if you've got an older baby or a toddler who's still only accepting puree, that is a reason for referral. Also just help looking at the family mealtime, the stress, anxiety, and the battles that can happen around feeding. That's an area that speech pathology can assist with. Tube feeding and tube dependency is also another area we work in. And then just to add that little safety point at the bottom, if there's signs of really wet voice or wet breathing after eating or drinking, can be signs of a swallowing problem and should be referred to a speech pathologist. Infant paediatric feeding is a specific area of speech pathology that requires further training and experience after qualification. So only some speech pathologists work with paediatric feeding. So in Australia, you can find those by going to the Find a Speech Pathologist search on the Speech Pathology Australia website, search under swallowing and dysphagia or infant feeding. Paediatric hospitals often have paediatric speech pathologists, or in metropolitan or regional hospitals where there's a paediatric speech pathology department, they will often work with feeding. Community health in some areas might do a bit of feeding work, and in some private practices as well do feeding, as I do in my private practice. Okay, key messages. So for the health professionals, thinking about children, you've got children that you see with EGIDs or EOE. The key message I'd like you to take away is to screen for feeding difficulties in these children. So ask all families affected with EGIDs about feeding and refer to feeding therapists when impacted. Now for those health professionals working with children with feeding difficulties, that might be the therapist, it might be the paediatrician seeing a child with a significant feeding problem, talking about screening for EGIDs in these. So my recommendation is that all children with feeding difficulties should be screened for EGID symptoms, particularly those without clear cause or with a protracted feeding difficulty, and then refer to medical GI evaluation. So this isn't children with just transient or very minor feeding problems. These are children who have significant feeding problems, refusal, aversion, problems with really limited intake or reduced appetite that's been going on quite a while. These children should be screened as well. And then my key message for families: feeding difficulties are relatively common but can be under-recognised. So sometimes it's hard to get that recognition that what you're experiencing with your child is a problem. So I do say to that, trust your gut as a parent about your own concerns. You know your child best. Seek out help if your child and family are struggling with feeding difficulties. There is help out there. And that it is better to identify and treat these problems earlier rather than later. It's much easier to make change when children are younger, usually, than when they're older, or if the feeding problems have been going on for a while, more entrenched, it can take longer. And just some key resources. I've got this GI Motility Online is a good resource for people looking for quite comprehensive information on their GI tract. In terms of family support, information advocacy, obviously Aussie, who's sponsoring this virtual talk, is a great resource for these families. And for feeding difficulties, Feeding Matters, an organisation in the US, but that has sort of like international reach. I recommend going to their website, a lot of great information there. For parents and therapists, this book, Helping a Child with Extreme Picky Eating by Cardia Rowell and Jenny McLaughlin, is a great resource. So they use responsive feeding therapy, and Cardiorel is the one who has the worry cycle, so you'll see that in that book. And then for those families or maybe like GPs or health professionals screening for feeding problems, if you're not sure if what your child's presenting with is a problem, you can go and do this questionnaire on feedingmatters.org. So you can go to their website, look for their infant and child feeding questionnaire. It asks you a lot of questions and you fill them out, and then it gives you whether that's something to go and see someone about or not, if there are concerns in those areas. I'll just put the references up here for those who are interested. I hope that was useful for health professionals and families. Thank you.